Assalamu alaikum. Good morning, everyone. I'd like to thank Dr. Musa and Dr. Abdullah and Dr. Fawaz for really doing a dedicated GIS complication symposium. I'm going to talk to you today about no reflow. This is a gentleman who's a 67-year-old who came in with an MI, had an EF of 25% with moderate MI, with moderate MR. On presentation, he was in heart failure, and he was having on and off chest pain. So he was really an unwell patient to start with. And this is his angiogram, and you're seeing a significant proximal RCA disease. The RCA is huge. It's giving collaterals to the left system. Another view, another aerial view of the RCA, you can really appreciate the significant disease in the proximal huge RCA, and the RCA is heavily calcified. His left system is pretty much non-existent. He has a stent in the LED, included circ, and severe disease that is hazy in the diag that we thought probably was the culprit for his presentation. The patient at this point was unwell, and we elected to just stop, put him back in the CCU, diurese him, treat him medically, and discuss what we're going to do. His LED is occluded. Surgeon looked at him for 30 seconds and said, no thanks. And we elected to bring him back for an Impella-supported PCI of his left system and then his RCA. We were really worried about the RCA being a very significant vessel. So that really was the discussion. What are we going to do? Are we going to optimize it, or are we going to do just a quick in and out stent? And because of the size of his RCA, we thought that it really needs to be very well optimized. It needs to be the full deal. We did a single stick, 7 French system. We ballooned and stented the diag, and we got decent results. This was relatively straightforward. The patient tolerated this very well. We started with the right, and again, you can appreciate the calcium even more. On IVUS, it looked circumferential, and it looked really, really significant. So we thought, all right, we're going to go ahead and do atherectomy. So we elected to do orbital atherectomy. You can see his hemodynamics here, and I just would like you to look at lead 2. You can see that the ST segment is isoelectric. You can see that the patient has a good blood pressure, preserved pulsatility. The patient here is doing very, very well. We started our rota run, and I must say we were not as slow as we ought to be, and his ST segment started to go up. Now, this is sped up, so what you're seeing, the hemodynamics that you're seeing are not moving by seconds. You're seeing essentially half an hour of work. But his STs are just creeping up. His PR interval is going up. His pulsatility is narrowing. And at this point, he had 2 runs of orbital atherectomy. And I must say again, we're done very, very fast, with less than 30 seconds in between 2 runs. And we didn't really inject any pre-treatment before. But then we got to a point where it was really apparent that the ST segment is going up. So what we did is we removed the Viper wire, put a microcatheter in, injected a lot of adenosine and a lot of nitroprusside. That really didn't help a lot. And then when we injected, we took a test. The contrast was just not going through. It was not even crossing the lesion. So in our minds, we were wondering if this was a no reflow coupled with a dissection or another problem proximally. So we thought, all right, we've pre-treated, we've waited, let's put a stent in. So we put the stent in, and that just made things a lot worse. The profound no reflow that we started with just got even worse. So the patient had chest pain, started moving, blood pressure really came down, ST segments were already going up and now doubled. We put the microcatheter again. We injected some more adenosine. Luckily, we had the pacemaker that we intentionally put it in for the orbital atherectomy. It really helped us just being very, very liberal with the adenosine. He required some pacing, or he used the pacemaker for a little bit of pacing throughout the case, but then recovered fairly well. I think what was extremely helpful in this case is the presence of the percutaneous support device. And I must say, prior to doing the case, we thought, do we really need it? Maybe we don't. And then my partner mentioned that, no, we do need it. And my opinion was, no, it's an overkill, but let's do it. And we definitely needed the device. So I'm really glad that we did it. So it's like the professor before me said, anticipation of no reflow and emphasis on time. Meaning if you start seeing no reflow, allow the patient to recover before getting a second hit on the myocardium, before causing no reflow again. The patient was weaned off the impella, and the impella was removed on the table. So again, try to anticipate and prevent no reflow. That's the best treatment for no reflow. And once it starts, just don't make it worse. Because when it starts, it will be okay and it will be tolerated. And I think we have this impulse that when we see something, we see the ST going up, we want to do something. Maybe the best thing to do is just remove your hands off the field, wait, let this ride, and don't make it worse. I think this case also illustrates something that is not related to no reflow, which is the patients that has a last remaining vessel, they really don't tolerate complications. We're used to acute vessel closure, and patients kind of do well, not when it's the last remaining vessel. That will have profound hemodynamic consequences. Thank you so much.
Thank you.